Okay, so this is a endocrine disorder. Dry erase marker. Yes, of course.
Any color.
Any color?
Any color. I don't care which color you got. Perfect.
I have green too. You want red and green?
Yeah. I have mine up there. Well, let me go all the way back up there.
No, no, no. That's fine. We're fine. We're just getting started. Okay, so endocrine disorders are disorders of secretion of chemicals called what? What kind of chemicals are secreted by the endocrine glands? What do we call them? Hormones. Hormones, right. So insulin is an anabolic hormone, normally secreted by where? The islets of Langerhans or the endocrine pancreas, right? That's it. Now, type 1 and type 2 diabetes are two different diseases. Type 1 diabetes is an absence of insulin production. So the islets of Langerhans of the endocrine pancreas have been destroyed by either an autoimmune process or something that we don't really understand. We call it idiopathic, meaning we don't know. About 10% of diabetics are type 1 diabetics. We don't use Roman numerals anymore. We don't say juvenile onset or adult onset. We say type 1 and type 2. Now, I guess the LD5 people are going to have lab, and we're going to talk more about that in lab today. I doubt LD1 will have their lab tomorrow. But you've still got plenty you can do. There's an entire chapter in IGGI. I believe it's chapter 67. You can check that for me. It's a whole chapter because there's a lot to know and a lot you're supposed to know about diabetes mellitus or diabetes mellitus. Okay? So type 1 diabetes is destruction of the insulin-producing cells in the endocrine pancreas, right? Type 2 diabetes is the other 90% of people with this disease. They can have decreased insulin production, but mostly what has happened over the years is they become what? Insulin resistant. Okay, they've kind of burned out their blood sugar management capabilities, and still are then prone to the same short and long-term complications. So the whole thing with diabetes is management of an incurable chronic disease, which is mostly what we're talking about in this course, right? And we wanted to have long-term blood sugar management. What's the normal blood sugar? 70 to 110, 60 to 120, right. So people that have diabetes mellitus, type 1 or 2, have hyperglycemia, right? Because either they're not making insulin or their body's not responding to the insulin they're making. And so this hyperglycemia over long term is what causes the short and long term complications. We're going to talk about the short term emergencies. Severe hyperglycemia in a type 1 diabetic. Severe hyperglycemia in a type 2 diabetic. So what's the severe hyperglycemic emergency in a type 1 diabetic called? DKA, diabetic ketoacidosis, right? What's the hyperglycemic emergency in a type 2 diabetic called? You've had all this before. HHNC or HHNK, right? Hyperglycemic, hyperosmolar, non-ketotic coma. So in either case, the patients are severely hyperglycemic. So they're going to have severe symptoms of the disease, right? And then anybody who's diabetic, who's managing their blood sugar, the opposite can happen, and that's hypoglycemia, right? So people that have severely low blood sugar have the classic signs of mild, moderate, or severe hypoglycemia. All of this is given to you now in the study guide. You have your outline for the PowerPoint in the study guide. You also have a lot of good pictures and handouts in the competency in the study guide. So starting on page 73, you have your objectives. I wouldn't worry too much about the articles unless you really have good access to them, because you're going to read the whole chapter 67 in IGGI. And it's all there. If you read it ahead, you'll know what I mean. Actually, you read it in a previous course. You're going to read it again. Then page 76, a couple pages of the outline. Page 85 are 86 are some case studies. Page 87, you have terminology. And then on page 89, 90, 91, 92, 93, you have some more additional handouts for this competency. Page 89 has a picture of DKA, et cetera, et cetera. There's a nice little picture of hypoglycemia. Well, page 93 is the sick day plan, what you teach patients with diabetes about how to manage their blood sugar if they're sick. So you know this, the answer to this question. What's the blood test we do now to look at long-term blood sugar management? Hemoglobin A1C, which is also called glycosylated hemoglobin, which looks basically at the thickness of the sugar coating on the red blood cell. And how long do your red blood cells live in circulation? 120 days. So if you're looking at glycosylated hemoglobin, or A1C, you're looking at 3 months of blood sugar management, aren't you? So people can't really cheat on their A1Cs. They can cheat on their blood sugar of the day they go to the doctor. But that doesn't mean that it's been 100 for the 3 months, because their A1C will give them away. What's the normal A1C? You want to try to keep it below 7 or 6.8. We used to say 7. We're trying to tighten it down a little bit. But people who are walking around with A1Cs of 12 are not managing their blood sugar. And they're the ones that are at risk for the complications. People think when they get diagnosed with diabetes mellitus that they're going to go blind, have kidney failure, and lose their feet. Well, is that automatic? No, of course not. That's possible if they don't do what? If they don't manage their blood sugars over a long period of time. If they keep their blood sugars in tight control, and with type 2 diabetes, that might be a number of things. Type 1 diabetics, there's really only one thing they can do. Well, there's only one medication they can take. And what is that? Insulin. Type 2 diabetics. Whatever it takes. Diet, exercise, oral meds, and insulin if necessary. So when somebody says, I'm type 2 diabetic, I'm never going to need insulin, that doesn't necessarily mean they will never need insulin. They need whatever works to keep their blood sugars in control. Can type 1 diabetics take pills? No. Because the pills are increasing insulin secretion or decreasing insulin resistance. And if they don't make any insulin, it's not going to work for them, is it? All right, good. Those are some basic concepts. Because we can go through a whole bunch of words, but if it's not making sense to you in your head, you won't be able to take care of your patients.
And you say A1C below 6?
Below 7.
7,
Below 7. They're trying to dial it down to like 6.8, 6.6. But 7 is what I think of. I still learned 60 to 120 for blood sugar. Now they're trying to say 70 to 110, a little bit narrower range. And then next week, we're going to finish up talking about diabetes mellitus, competency 7, and we're going to do all of competency 8, which is the rest of the endocrine system. We'll talk about pituitary, the posterior and anterior pituitary hormones, and the endocrine disorders of hypo or hyper pituitary. We'll talk about the thyroid gland and disorders of hypo or hyperthyroidism. We're going to talk about the adrenal glands, the adrenal cortex, hypo and hyper adrenal cortex, and the rest of the adrenal gland. We're not going to do reproductive hormones, but we're going to do pituitary, thyroid, and adrenal endocrinology next week. So between now and next week, if you get snowed in, read everything for competency 7 and competency 8, because at the end of next Wednesday, you'll have had all the endocrine content for this nursing program. So the nice thing about the endocrine system is you can be hypo, which means the secretion of those hormones by that gland is decreased, low. Or you can be hyper of whatever that gland is that's secreting those hormones. And if you're hyper, you are over-secreting. You have too much. Okay, so it's really a neat system once you get once you understand how it all interconnects. All right, and next week we'll talk about diabetes insipidus, which has got nothing to do with blood sugar. Diabetes insipidus is antidiuretic hormone from the pituitary gland. So DI, sometimes hear it called, is about water balance. So today we're going to talk about, or review, most of you hopefully know something about diabetes mellitus, which is insulin secreted by the endocrine pancreas. The pancreas also has an exocrine function. It also secretes what? Digestive enzymes. Right. But the endocrine pancreas secretes the insulin. And it works with glucagon, and it works with the liver to manage carbohydrate, fat, and protein metabolism, which is what this says here. DM is a heterogeneous group of chronic systemic disorders, which means it can affect all body systems, affecting metabolism of carbohydrates, protein, and fat because of insulin deficiency or insulin resistance. And we know insulin's a hormone made by the beta cells in the pancreas, and it does help the body store and use the carbohydrate, fat, and protein. So if somebody has high blood sugar, which is diabetes mellitus or mellitus, they're going to have polyuria, polydipsia, polyphagia, and a fasting hyperglycemia. So the hyperglycemia leads them to have the polyuria, which means what? What's polyuria? Increased urine output. And if somebody's putting out large volumes of urine, they're going to have polydipsia, which is thirst, polyphagia, which is hunger. Okay, and the polyuria, if you put out a lot of urine, what happens to you intravascularly? You can become dehydrated, right? So when you talk about severe hyperglycemia, the signs and symptoms of those disorders, emergencies, are severe dehydration. We know that it's the 7th leading cause of death in the United States, that we have 8.3, and some people are saying higher, of the population in this country, or about 26 million people, are affected by diabetes. 7 million people aren't aware that they have diabetes mellitus. Now, would that be the type 1 diabetics or the type 2 diabetics? Type 2. And that's the one where the incidence is rising. And the incidence is rising for a number of reasons. We're hoping to stem the increase, but so far we haven't made a lot of inroads in the obesity epidemic, particularly in children and young adults. Prevalence is similar for men and women. We used to say that type 1 was juvenile onset and type 2 was adult onset. But guess what's happening now? There's an increased incidence of type 2 diabetes in children and adolescents. So we now have younger people developing type 2 diabetes. Higher incidence in certain genetic groups. Genetics is a powerful thing. If you have genetics of African or African American, Native American, Hispanics are a pretty diverse group. Mexican Americans, particularly if they're related genetically to Native Americans, American Eskimos, etc., from those genetic backgrounds. Okay, so there is genetics at play. It says minority group members have a higher risk of complications than Caucasians, even after adjusting for differences in blood glucose control. So we know that there are different dietary habits, etc., that can be at play, but there's also a genetic component in addition to that. We know that diabetes mellitus is the leading cause of new cases of blindness, chronic kidney disease requiring dialysis or transplant, and foot or leg amputation. So we just talked about chronic kidney disease, and we know that diabetes mellitus is one of the most common risk factors. Okay, type 1, insulin dependent, autoimmune disorder generally, beta cells are destroyed. And you can see little tiny young kids with type 1 diabetes. You'll see that in pediatrics in a place like Children's Hospital perhaps, where they're diagnosed sometimes at age 2 or 4 or 6, young children. Adults can be diagnosed with type 1, but it's more commonly diagnosed in children and young people. Abrupt in onset, requires insulin to prevent ketosis and sustain life. So without insulin, and before we had insulin, type 1 diabetics died of their disease. About 10% of the diabetic population has the type 1 form. They tend to be thin and underweight. I said it occurs primarily in childhood, and we think it could be a viral initiation with the autoimmune destruction, but we're not really sure about the cause of autoimmune diseases, are we? All right, so 90% is type 2. These folks have a reduction in the ability of cells to respond to insulin. We call that insulin resistance. Poor control of liver glucose and decreased beta cell function. So there could be some decrease in the function of the beta cells and the insulin secretion. We do know that type 2 is generally slow in onset, and it's all about controlling the hyperglycemia, isn't it? And whatever it takes. So tell me some things that people do with type 2 diabetes to control their hyperglycemia. Medications. This says here insulin or an oral agent. We'll talk more next week about the oral agents and the insulins. You're going to talk about the insulins in lab, if you have lab. If not, there's a really good section in the study guide in the back Real quick, turn with me to page 237 in your study guide. In the appendix. There is a picture. What's it say? Hyperglycemia. You've probably seen this as patient education material. And it has nice pictures of the signs and symptoms of high blood sugar, right? And we'll talk in a minute here about the hyperglycemic emergencies. Page 238, what's that say? Hypoglycemia, okay. And it shows you what signs and symptoms somebody would present with if they're getting mildly low blood sugar, right? Page 239 asks you to fill out a chart. These are helpful study guides for you. You're going to look at hypoglycemia, hyperglycemia, DKA, and HHNC. The factors that can precipitate it, the common abnormal lab values, and then what's the bottom column or row say? Priority emergency interventions. What does the nurse do first? What is the initial intervention or action? Okay, so I'm getting to the point I was making here. Page 240, there's a chart on insulin. Okay? As I said, next week, come prepared to talk about insulins and oral agents. The best chart we have for the oral agents, I know there's charts in your reading in the chapter in Iggy, but I like this little page 241. This gives you a list of the most common FDA-approved oral anti-diabetic agents. Okay? And they divide them into class 1, class 2, and class 3. You see that? So up here where it says may require insulin, one of the types of insulin or combination of insulins, or sulfonylureas. Those are the original, most commonly used class 1 oral anti-diabetic agents. Okay, and it says that on page 241. See the sulfonylureas? Okay, so look at those. Have you heard of glucotrol? Glucotrol is one of the second generation sulfonylureas. What does it say it does?
Delays the absorption.
Well, class 1 says it stimulates the beta cells to release more insulin, right? And then the metglitinides are another newer category of type 1, or class 1. Class 2 is the biguanides, and that is what? What's the one available in this country? Metformin or glucophage. The thiazolidinediones, I had to practice that. You like that? It's all in your phonetics. And those are drugs like Avandia, which recently have come under fire and is not as widely used anymore because people had heart failure. And then the class 3, what's it say it does? Slows or blocks the breakdown of starches and sugars, and that's your alpha-glucosidase inhibitors. And those act in the GI tract. Okay? So hang on to that. And then after that, in your study guide, I think there's like 1 or 2 more handouts that are diabetes. There's one on giving insulin, teaching your patients to properly give insulin injections, and then on blood sugar monitoring. Okay? So I wanted to make sure you saw all of the resources that are here for you in the study guide. All right. So tell me about the risk factors for type 2 diabetes. All right, obesity, hypertension. What else? Family history, good old genetics. If your parents had it, your grandparents, etc., you're at higher risk. Okay, so genetics, minority races. We talked about people of African descent, of Native Americans, Eskimos, Mexican Americans, etc. Age, yes. Generally, type 2 diabetes incidence does what? Increases with age. But who's now at risk in our current society, our fast food, sitting in front of the TV society? Younger people, teenagers, young adults, with other risk factors are now developing type 2 diabetes at higher rates than they used to. Okay, hyperlipidemia. So people whose lipid profiles show that they have high cholesterol, high triglycerides, make that person at risk. What about this one here? History of what? Gestational diabetes. Now, if you're a really big person and your, spouse is big or your partner is big, then that's a big baby. But a baby of a woman who has had gestational diabetes, that would put that person, that woman, at risk of developing type 2 diabetes later in life. Okay. Okay, so we're not going to really get into gestational diabetes. You all studied that in a previous course, right? And it's really important for that woman during her pregnancy then to manage her blood sugar. And what again is the test we use for blood sugar management over a 3-month period? Hemoglobin A1C, glycosylated hemoglobin. I thought that was cool the way my colleague described. He did patient education for diabetes at Greater Southeast where I worked for 7 years. And he said it was the thickness of the sugar coating on the red blood cell. And that's kind of what it is. It's the glycosylated hemoglobin, the sugar added to the hemoglobin molecule on the red blood cell. Okay. And we said gestational diabetes is during pregnancy, and that person would be at higher risk later in life for type 2 diabetes. Okay. So chronic complications. Let's talk about the complications. We mentioned that we have patients who, when they're diagnosed with diabetes mellitus, say, well, I'm going to go blind, they're going to cut off my feet, and I'll be on dialysis. Why would those things develop? Because of the vascular complications. It affects the basement membrane of the arteries and veins, and it can decrease circulation. Now, macrovascular, what's macro mean? Large vessels, large blood vessels. So we're calling macrovascular complications the large blood vessels that go to the heart. So what's the person at higher risk of? Coronary artery disease, which can lead to heart attack, myocardial infarction. What's a myocardial infarction caused by? The blockage in the coronary arteries that perfuse the myocardium, right? Okay, so if somebody has severe arteriosclerotic plaque in their coronary arteries, they're at higher risk of MI or heart attack. All right, we also know about the peripheral vascular disease. You studied PVD before PAD. If somebody has decreased circulation to their extremities, say the feet, what are they at risk for? Amputation. So it's really important when people have diabetes to teach them about foot care, about maintaining. So what do we teach them about foot care? You've had this before.
Make it clean.
Inspect their feet.
Walk with shoe. Don't walk without when you're barefoot.
Don't walk barefoot. Closed-toed shoes.
Keep it dry.
Keep it clean and dry. Be careful cutting their toenails, or make sure a podiatrist or somebody does it. Nurses generally do not cut toenails of people with diabetes. It depends on where you're practicing and what your level of practice is, but okay. And then cerebrovascular disease. That's talking about the blood flow through the, where? Brain, cerebrovascular. So those people are at risk of a brain attack, which is another term for stroke, which is another term for cerebrovascular accident, which is clots or bleeds in the vascular system of the brain, right? So these are the large vessels that tissue perfuse these organs. We also have smaller vessels, so it really doesn't matter whether they're macro or microvascular complications, does it? Because the microvascular complications can be just as bad. So ocular means the blood flow to the eye. So we know about diabetic retinopathy. People can develop blindness from retinopathy, the retina. They can also get increased risk of retinal detachment, of macular degeneration, and cataracts and glaucoma. So blindness, again, the most common cause of blindness in this country is the diabetic complications. What about neuropathy? What do we teach? What would be the signs and symptoms of peripheral neuropathy? Neuropathy. Paresthesias, right? So they can have a lot of numbness. Numbness and tingling is paresthesias, right? From the neuropathy, diabetic neuropathy. So what do we teach them if they have numb feet?
To check the temperature of the water.
Don't burn their feet. Make sure that they check the temperature of the water before they put their foot in. Because if your foot is numb, not only are you at risk of burning, but you could also be weaker and have a risk of injury, of falls, right? Okay, that's because of the neuropathy. You've got to know the pathophys to understand the reasons for the signs and symptoms, which drives the rest of your nursing process, including the teaching. Autonomic neuropathy. People can develop what we call diabetic gastroparesis. Gastroparesis. One of your case studies in your study guide for this competency talks about a woman taking Reglan, metoclopramide, which is an anti-what? Metoclopramide, Reglan. Why do we give people Reglan? What kind of drug is it? Antiemetic. Good. Okay, so metoclopramide. I know I gotta stop doing the brands because it's not on the Inclix anymore. Metoclopramide or Reglan. Anybody know how it works? It increases GI motility, right? So we use it for patients with G-tube feedings that have high residuals. Because if they have a high residual, things are going through too slowly. So Reglan or metoclopramide, not to be confused with metronidazole, which is Flagyl, which is an antibiotic. Metoclopramide or Reglan is an antiemetic. Works by increasing GI motility. Okay, so if somebody has, and this is your case study, which is why I'm bringing this up. If somebody has diabetic gastroparesis, what do you think gastroparesis is? Weakness is paresis, right? Gastro is your stomach. So somebody that has gastroparesis is going to present with a lot of vomiting, because things aren't moving through. So if you have decreased nerves to the stomach, you can get diabetic gastroparesis. So in gastroparesis, you have decreased motility. Causes a lot of nausea and vomiting. And it can be very disabling. Gastroparesis, for whatever reason, people do a lot of vomiting and it can get dehydrated and electrolyte imbalances, right? So Reglan is the treatment. Reglan is one of the medications they can give, and it talks about this in your case study, to increase GI motility. So we use it for high tube feeding residuals, we use it for gastroparesis, we use it as an antiemetic for people who have nausea and vomiting. Okay? What's the antiemetic we use now that's like the best category of antiemetics? Ondansetron, which is Zofran. The ancetrons, Kytril, Oxy, Zofran, they're all ancetrons. And those are really good because they act on the vomiting center in the brain. They're what we call 5-HT3 antagonists. We'll talk about that when we do chemo. Okay. And then nephropathy. So we just studied and got tested. You just got tested on chronic kidney disease. And we know that the kidneys, nephro, the perfusion of the kidneys can be affected over long term with the complications, the vascular complications of diabetes. And then we have male erectile dysfunction. It's a billion-dollar business these days to sell ED drugs, isn't it? And a lot of the men taking this are either on beta blockers and other antihypertensives that are causing ED, or maybe they have some kind of blood flow problem to that area from diabetes or hypertension or whatever. Okay, so erectile dysfunction is also one of the things you can see with people with diabetes. As they say in the commercial, it's a question of blood flow. Well, duh, yeah, it is. Okay, so the complications. So you need to know about the acute complications, either hyperglycemic complications or hypoglycemia. So let's talk about that. You did say, because I asked you, that DKA or diabetic ketoacidosis occurs in type 1 diabetics. It can be precipitated by an infection, an illness, a GI bug, and then it's preceded by polyuria, polydipsia, and polyphagia. So what do those three symptoms, the three Ps, sound like to you? They're the symptoms of hyperglycemia. They're the symptoms of diabetes. So when we do labs on somebody who's developing DKA, a type 1 diabetic with a very high blood sugar. So again, if your normal is 60 to 110, and they're above 300 milligrams per deciliter, that's very high in a type 1 diabetic. They can't tolerate really high blood sugars without getting really sick. The arterial pH. So when somebody has acidosis, what happens to their pH? What's your normal blood pH? 7.35 to 7.45. So if it's below, either very low normal or below 7.35, 7.38, we know that that's acidosis. So is this a metabolic acidosis or a respiratory acidosis? It's a metabolic acidosis. Okay. So we're going to see a low blood pH along with a low bicarb. Now this should be a greater than sign. The sodium's greater than 136 because again, with a polyuria they're going to get what? Dehydrated. And then with dehydration they'll get hemoconcentrated and these electrolytes will look high. So the sodium's high, the BUN is high, the creatinine can be high, and they can have ketonemia. That's the hydrogen ions in the blood, or ketonuria. So how do you know if somebody has ketonuria? You dipstick it with one of those old-fashioned things. I'm so old, I've been a nurse 40 years. I remember dipping the urine for blood sugars. Now, you don't spill, the renal threshold for the urine is 180, so they were really high by the time we saw it on the dipstick. But now we still dip urine for ketonuria. And if it turns purple, dark purple, whatever, we know that they're spilling ketones in their urine. And that's not normal. Okay, with severe hyperglycemia, in this case DKA, they have the metabolic acidosis, and they're also going to have the symptoms of the dehydration. So what are some symptoms of dehydration you see? Decreased skin turgor, dry mucous membranes. They can get dehydrated. They can actually start to have lower blood pressure, increased pulse to try to keep the blood pressure up. What's tachypnea? Increased rate of breathing. Okay, something called Kussmaul's respirations. You'll see that. We mentioned that when we talked about metabolic acidosis in patients with renal failure, right? So it's a pattern. It's an abnormal respiratory pattern. And what does it look like? Kussmaul's respirations, we said it before, it means they're breathing rapidly and deeply. Deep, rapid respiration. Good. Don't do it, you'll hyperventilate. But yes, but what's the purpose of it? Blow off the hydrogen ions. So it's the respiratory compensation for the metabolic acidosis, right? Because if you have a metabolic acidosis or alkalosis, the compensation is with your respiratory system. If you have a respiratory acidosis or alkalosis, your compensation is through your kidneys. Okay. Abdominal pain, nausea and vomiting, all these things can happen with severe hyperglycemia. And this is the diabetic ketoacidosis. So then they're going to have the symptoms of the hyperglycemia affecting their level of consciousness. People can get lethargic. They can end up in what we call a coma. And they can come in how? When we teach the EMTs, we always tell them if somebody's down in the field to do what? Check their blood sugar, right? Why? Because we don't always know if the fruity breath, if the decreased level of consciousness, they might be confused or combative, whether that's from some other cause, like alcohol, or whether they're diabetic and DKA. So it's easy to grab a blood sugar with a glucometer and see, oh, this patient has really high blood sugar, they're in DKA. Or, oh, they have a medic alert bracelet that says they're a diabetic, a type 1 diabetic, or any kind of diabetic. Okay, because it affects their level of consciousness. Now, if you're really high, severe hyperglycemia, it can be decreased LOC. It can also be if they're really low. So either way, they're going to have risk of injury, safety issues, and change in mental status. All right, so DKA. Monitor the clients for signs and symptoms of the disorder. Check blood pressure, pulse, respiration until stable. Record urine output, temp, mental status every hour. Assess their LOC, their hydration status, which is from their fluid and electrolyte balance, their intake and output, and the blood glucose measurements every hour and then every 4 hours. So this would happen in the field, then in the emergency department, then in the ICU, and then possibly on the floor after the ICU. Most places you don't run insulin drips on the floor, unless it's a special diabetes unit. So here's the take-home message. What is the treatment of DKA? There's two major things. Well, of course you have airway and breathing. But then what are you going to treat it with? Insulin. Because if they're severely high, the treatment is insulin. So they'll give them a bolus of insulin, usually regular. They can use the rapid-acting, Humalog and Novolog, but usually it's regular. And then with an insulin drip. And the insulin drip gives us certain numbers of units per hour as the blood sugar comes down. So regular insulin is the insulin used in a drip. It makes sense, I hope, that you wouldn't want to use a longer acting insulin, an NPH, which is intermediate acting, or Lantus, which is long acting. You can't use those in a drip. You have to titrate the rapid acting, or short acting rather, insulin, which is regular. And then as the blood sugar drops, you're going to follow them for hypokalemia. I think we mentioned this, that one of the emergency treatments for high potassium is to give insulin. Insulin will drop the potassium. That's a good thing if you're trying to treat hyperkalemia. But if they have normal potassium and you're treating the hyperglycemia, you still have to watch their potassium. And these are the symptoms of hypopotassium. And then you're going to watch their blood sugars and their potassium as their blood sugar is coming down. Okay? Yeah.
Well, with the insulin, you have to give them fluids too.
Insulin and fluids.
And so.
Absolutely. I think that says that, doesn't it? Yes.
Oh.
Okay. So insulin and a lot of fluid. Exactly. So here's my question. What solution do you think would be used initially along with the insulin or to make the insulin drip to treat DKA or HHNC? What fluid? It's got to be IV because they're not, safe to drink. Normal saline. 0.9% isotonic normal saline. So you don't want to give dextrose, do you? No. That makes no sense. You don't want D5 or D10 or D anything because that's sugar. So you want isotonic saline. You want to keep you want to increase intravascular volume without making the blood sugar worse. And then you're going to give a lot of volume. And while you're doing that, you got to make sure you're giving the right amount for the dehydration without too much. Because if you fluid overload somebody, then they can get heart failure and pulmonary edema. Pulmonary edema is from left-sided heart failure, isn't it? It's from giving too much fluid and it's backing up from the left heart into the vascular system of the lungs. But you need to replace the fluid loss. And then after you replace the fluid loss, you treat with insulin, the blood sugar comes down. You want to try to prevent it in the future. So the person with type 1 diabetes needs to make sure they contact their health provider, which could be an advanced practice nurse like a diabetes nurse educator, or an endocrinologist or other physician, if their blood sugar is higher than 250, if they have ketonuria, which is ketones in the urine for more than 24 hours, and if they're just not able to keep fluids down, they're going to need to seek treatment. Okay? And in the video you're going to see in lab, I don't know when the people for type LD1 are going to see it, but anyway, it does go through the treatment of DKA, HHNC, and hypoglycemia.
Ms. Fang,
Yeah.
do you happen to know of any abstract, like YouTube videos or anything?
There's all kinds of good stuff.
Okay.
Maybe we can find something and put it up for you guys.
Okay.
Because there's a lot of good stuff on diabetes. We don't want to overload you.
Right.
But there are some good things that you can get on YouTube or through the Blackboard. And that
Okay.
kind
I
of stuff.
just didn't know if there was
A lot,
something
has anybody ever gone on the library video resources? They're wonderful. You can go into the library website, click on video resources, log in, and then there's a whole bunch of nursing skills.
You can go to Kaplan too.
Kaplan has it too. Kaplan has some good stuff. Now I know this. You're going crazy with this diabetes case study. It's pretty intense. That's another thing that you're going to be doing anyway. But you're talking about some other videos if you don't get to see the video in lab.
Yeah.
That cover basically the same thing. Yeah. If you just go in and you put in DKA, HHNC, or hypoglycemia, you'll probably get a lot of hits.
Okay.
But I can't verify the quality of them.
Okay.
Yeah. Good question. All right, so that's DKA in type 1. So who gets HHNC? Hyperglycemic, you know what that means. Hyperosmolar, which is from the dehydration. Blood gets kind of thick and sludgy. Non-ketotic coma. So it's hyperglycemia without acidosis. They don't have metabolic acidosis. The absence of ketosis and very high glucose. Now, type 2 diabetics can walk around, I've seen them, with a blood sugar of 800. They don't feel very well. I've seen 1,000. So above 800, this is really going to become a problem. They're going to have a lot of polyuria, a lot of dehydration, get a very high serum osmolality, blood is thick and sludgy. So the dehydration and the electrolyte loss occurs, and then there's decreased renal blood flow. And we know that decreased renal perfusion can cause decreased urine output or kidney problems. Occurs mostly in older adults and in people with type 2. So any kind of illness, sepsis, MIs, pancreatitis, strokes can cause it or precipitate it. There are a lot of drugs we give, a lot of treatment with a lot of medications that can actually increase their blood sugar. What's the big offender? Drugs we give a lot, powerful anti-inflammatories. Glucocorticoids, also called corticosteroids. If we give somebody a cortisone type drug, and what are some of those? Prednisone, dexamethasone, fluticasone, solucortef, solumedrol. All of those can increase your blood sugar, right? We call it steroid-induced hyperglycemia. So if the person already has hyperglycemia from diabetes and we give them steroids, we made it worse. Diuretics sometimes can affect fluid balance. Phenytoin is what? Dilantin. And some of the other anticonvulsants can mess up blood sugars. Propranolol, calcium channel blockers. Why do we give those? Antihypertensives, right. Okay, cardiovascular drugs. And then the older people are at more risk because they have decreased thirst perception. They can't tell that they're thirsty as much, they don't drink as well, and their kidneys aren't as effective for concentrating urine. So the same treatment. We want to give lots of IV fluids for the severe dehydration, and we want to bring down their blood sugars. So it's IV fluids, and what's the fluid generally initially? Isotonic, 0.9% normal saline, along with insulin. Insulin bolus, maybe an insulin drip, and then we monitor the electrolytes, the fluid balance, and the blood sugars as it's being treated. Signs of cerebral edema, not just fluid overload that could affect the heart or lungs, but it can also affect the brain. You want to monitor neurostatus. They might have decreased level of consciousness from the HHNC. As we're treating the hyperglycemia and their blood sugar's coming down, they should get more awake. But if we're fluid overloading them and they're getting cerebral edema, then we need to do good neuroassessment. Level of consciousness, pupil checks. Of course, if somebody has seizures, that would be bad. All right. So HHNC is the hyperglycemic emergency in type 2. Anybody with diabetes can get hypoglycemia, right? We want people to have tight blood sugar control, but now that we're doing a lot of tight blood sugar control, where they're doing their AC and HS blood sugars, which means they're checking their blood glucose 4 times a day and treating it, to keep it within normal range, they're having a higher incidence of hypoglycemia. So people need to know and recognize the signs and symptoms of mild, moderate, and severe hypoglycemia, as do you as their nurse. Okay, so if their blood glucose drops below normal, we can get what we call neurogenic symptoms. And what do people feel? They feel, read it with me, hungry, sweaty, weak, shaky, nervous. All of those things are from the drop in blood glucose below normal. Also, they can get what we call neuroglycopenic symptoms, just means how the low blood sugar affects the brain. They can get headaches. As their decreased level of consciousness, they can start to slur their speech, get a little confused, act irritable or cranky, and then pass out. So with very low blood sugar, they're still comatose, just like if it's really, really high. You have to figure out which it is by doing a blood glucose. Interventions for hypoglycemia. Well, that's why we never give somebody meds that are anti-diabetic or hypoglycemic meds unless we know what their blood sugar is. Before you give the morning meds, whether it's insulin or pills, you need to know the blood glucose, right? If they're NPO, you don't give them. If the patient's symptomatic of hypoglycemia, grab a blood glucose. Find out what their blood sugar is. Okay, so what do we give patients for mild hypoglycemia? They're irritable, shaky, weak, hungry, headachy, but they're still conscious and safe to take oral. All these things that are what? What do these look like to you? They look like rapid sugar sources. There is such a thing as glucose tablets. You can buy them at the drugstore. But 4 ounces of orange juice works just as well. 4 ounces of non-diet sugar soft drinks. You can give hard candies. They can eat 2 teaspoons of sugar off a spoon. They can do saltines, graham crackers, milk. All of those kinds of things can increase their blood sugar. And you know, I've seen overkill too. Patients a little bit hypoglycemic and they're drinking like 4 gallons of orange juice. And then, of course, shockingly, their blood sugar is really high an hour later. So when they mean 4 ounces, they really mean 4 ounces, unless you're finding them lower than 60, or lower than 40, rather.
And that's when they give them the glucagon.
Yeah. Now, here's moderate. Now they have cold, clammy skin, weak, rapid pulse. It's affecting them. Marked changes in mood, drowsiness. Now their blood glucose is less than 40. Now they need 15 to 30 grams. Now they need more orange juice. Rapidly absorbed carbohydrate. And then additional food, low-fat milk or cheese, which gives them a complex carbohydrate that lasts longer. The problem with the simple sugar is the blood sugar goes up and then it drops pretty fast. If it's severe hypoglycemia and you don't think they're safe to take oral, now you got to do D50 if you have an IV site, or you can start one. 50% dextrose is a concentrated, it's in the emergency carts, it's in the emergency drugs. Apparently they're having some shortage of D50 in hospitals right now. Probably the companies that are making it aren't making enough money. So D50 would be given IV push. If they don't have an IV, they can give glucagon. So you may have seen glucagon. They can give that sub-Q or IM. Either way, those will increase blood sugar quickly in a patient who can't take oral treatment. Okay? And then what are the common causes of hypoglycemia? Well, what are things that decrease blood sugar? Exercise, insulin or other medications, alcohol can actually spike and then drop the blood sugar, or lack of eating. So if they're going to take their meds, they need to eat. And this just says encourage them to wear an ID bracelet, so that if they have hypo or hyperglycemic emergencies in the future, they can be treated effectively and quickly. Okay? So patients need to know signs and symptoms of hypoglycemia, what to do about it, mild, moderate, severe, and what type of hyperglycemic emergency they could be at risk for, what the signs and symptoms are, and what the treatments would be. All right. This is kind of where I'm going to leave it. Collaborative management, the nurse, the physician, the rest of the nursing team, and of course the patient and the patient's family. So you want to know information, data about the patient. What's the patient's age, the birth weight of his or of her children? Has that person lost or gained weight? In type 1 diabetes, it happens pretty quickly. They get sick quickly, and sometimes in that case they may have lost weight. With type 2 diabetes, usually happens slowly over a long period of time. They may have actually gained weight. Occurrence of an illness or extreme stress that may have set it off. If they're a known diabetic, have they been taking their insulin and or other medications properly or not? Have they changed their eating habits? Have they changed their activity or exercise habits? How long have they had 3 Ps, polyuria, polydipsia, polyphagia, and feeling lousy and fatigued? Have they had small skin injuries, becoming infected more easily, taking a longer time to heal? We know that people with hyperglycemia have sugary wounds. What happens to sugary wounds? They're a medium for bacterial growth. So they have less perfusion, usually not as good circulation, and they're at more risk for infection. A history of other concurrent cardiovascular disease, hypertension, heart failure, other kind of cardiac dysrhythmias, or cerebrovascular diseases like strokes. All right? So now, this is on to risk for injury, but we're going to start next week and finish talking about the medications. We're going to talk about the oral agents, we're going to talk about the insulins, and then a lot of the other teaching stuff. You know, managing their glucose, exercise, diet, etc., etc. Okay?
Thank you.
All right, that's enough for now, except some of you I'll see you in lab at 12 o'clock.
Thank you.
And we'll do more. All right. Everybody be careful out there tomorrow. I guess some of you will get your charming children again another day. If you have kids at home from school.
School's canceled for your kids.
Next Thursday, you'll get a super lab.
Because she works for the school.
Super lab. LD 1 and 2, if you miss lab tomorrow, we're still going to try to catch it all up next Thursday. We'll do a little bit on TPN, we'll do a little bit on diabetes, and we'll do a little bit on What's next week? Next week is tests, diagnostic tests. So we can do all that in one lesson.